Good morning, everybody. I am neither Robert Gross or Robbie Schnall, but I've had the pleasure of working with them over the last couple of years on a smoking cessation trial in Botswana, the Thotloetso trial, which means encouragement in Setswana. Okay, so people living with HIV are actually 2 to 3 times more likely to smoke than than the rest of the general population. And this isn't any different in Botswana. About 50% of males living with HIV in Botswana smoke tobacco. Smoking cessation is not really a thing currently in Botswana. The only available medication for smoking cessation is nicotine replacement therapy. This isn't something that is available within the government healthcare system, and so people would have to buy these things out of their own pocket, and it's probably a little bit cost prohibitive for the average individual. And even within the government healthcare system, there's really no available counseling that is happening. So Robert and Robbie came together and designed a novel intervention that is derived from depression treatment. This was a behavioral intervention, and they used prior depression treatments because of the link between HIV and depression, as well as the link between depression and smoking. And they used this in combination with MAPS, which is a problem-solving, also behavioral intervention that was used successfully for adherence to medications. Individuals would undergo 5 sessions and would also get homework, and this would be delivered by telephone. So they had a pilot trial that looked like there would be preliminary efficacy with this intervention, and so they went ahead with the Thotloetso trial, which was a randomized control trial where individuals were either randomized to BAPS, which is this novel intervention, versus standard counseling. And individuals were then assessed at various weeks, with week 24 being the final outcome of whether or not individuals had stopped smoking. So to look at the baseline characteristics of the individuals who were involved in this trial, 651 individuals in total were recruited and randomized between these 2 arms. Individuals were middle-aged, reflective of the people who smoke in the country. More than 80% of these people were men living with HIV. As you can see here, they had very high depression scores. About 60% of people recruited had high depression scores, and 20% of individuals had hazardous alcohol use. So week 26 is where they assessed abstinence, and this was assessed if an individual at week 24 reported that they weren't smoking anymore. They actually had a CO confirmation, a breathalyzer test that tested to see if they had been smoking. What was surprising in this trial is that about nearly 40% of all individuals who were involved with this trial actually stopped smoking. And a little bit of context, in the global north, you expect with behavioral interventions only about 10 to 15% of people to stop smoking. So about 40% of individuals within this study stopped smoking, which was really high. Also, I wanted to highlight the session completion rates, about 80%, which is quite high for randomized controlled trials, and there was no difference in treatment efficacy by sex or depression status, which is something that we were looking to see. So in conclusion, both behavioral interventions were really effective. Anecdotally, the standard counseling was easier to deliver, and they had slightly better attendance rates and slightly better quit rates. This work is going to be presented to Botswana's Ministry of Health and other stakeholders next week. We hope to help them with developing guidelines for smoking cessation within the public healthcare system. And we think that probably an intervention that is telephone derived is going to have the most success. Future work that Robert and Robbie are looking to do is bringing medications for smoking cessation. Cysteine is a plant-based, cheaper alternative of varenicline, and they're hoping to do a trial that does medication in combination with counseling in Botswana. Thank you.